The podium mic's off. Okay, there we go.
Mine was on or off?
Yours is on.
On.
Okay. Good afternoon, everyone. Want to get started here, but before we get started, I wanted to talk to you a little bit about some changes that I'm making in the guided case review sessions. And this is in response to the survey that Jojo and Brent circulated to you. First of all, I want to really thank your class officers, Jojo and Brent. I know they're not here. They're about to run in Memphis, along with, looks like, half the class, but that's okay. It's a good cause. We got about 50 responses. I was very pleased that at this early stage, about 60% were positive. And through the Google Doc, I picked up about 8 common concerns and suggestions. There were some other items, and I may or may not be able to deal with them, but I wanted to address these 8 so that we know what we're doing going forward. Okay, so first big concern. Downloadable PowerPoints would help us follow cases. Well, you're absolutely right, and they're on Canvas when class starts. If you log into Canvas today, you'll find Dr. Natteru's slide set minus answers. Non-graded questions would reduce stress. Yeah, I agree. So we will switch to quizzes of some sort, weekly or bi-weekly. I may ask for you to follow up with Brent and Jojo to tell me which you'd prefer. Some students like the small quizzes weekly, some students like larger quizzes bi-weekly. Doesn't matter to me. It's nice to know that I can make people happy. All right. We appreciate 10-minute breaks each hour. Well, I agree, and I understand that, so we'll start today. So at 1:50, we'll take a break, start back up at 2, assuming that Dr. Natteru hasn't finished up by then. It's hard. I'm going to put this one up because it was an important one. It's hard to hear the clinicians when people whisper or talk. Well, I agree. However, that's between you and your classmates. So you're going to have to deal with it. As long as it doesn't involve visible bloodshed, I'm cool with it. Visible is the key word. Shorter sessions. I agree. When I started this off, I needed to find out what the optimal number of cases were. There really wasn't anything in the literature on that. Looks like it's between 4 and 6. So it's probable that going forward these sessions will run about an hour and a half. If that's where they run, I'll still break it at the hour just to keep consistency, but we'll go from there. The case developer should be present. I agree. We had some scheduling problems starting up, partly because we backed up the course a couple of months, but those are being resolved. And starting in January, starting today, because Dr. Natteru was the case developer. Questions should be board style, vignette, STEM, multiple choice questions, one right answer. Well, that would be true if these questions were really intended as kind of summative, graded questions, but the questions are actually really intended to generate discussion and help the clinicians leading the session see when there are gaps in knowledge. So if there's a question that half the class got right and half the class got wrong, that's a cue for the leader of the session to stop and try to resolve that confusion, okay? So that's why the questions are written the way they are. The exam questions will in fact be written that way, and when I start up the quiz questions, they'll probably be written that way, although I have to do some research to decide, or do some thinking to decide what I want the quiz questions to be picking up, okay? And then finally, the guided case reviews should be voluntary attendance. Well, the problem is this kind of session doesn't really work asynchronously. It's easy to do a lecture asynchronously. It's really virtually impossible to do a give and take session asynchronously. So that's why they're mandatory. It's not to torment you. It's just that this approach to teaching doesn't work that well otherwise. So I want to thank you again for your feedback. It's been hugely helpful. Feel free, either directly or through your class officers. If you got more feedback, I want to hear it, okay? You know, as I've said, this is the first time we've tried this approach out. We need all the help we can get to make it work as well as it possibly can. All right, so with that, I'm going to turn the session over to Dr. Natteru, and we'll go from there. Yes, ma'am.
So is today for grade?
No. Okay. Nope. No questions for grade during this session from here on in. Okay? Here you go, sir.
Mic's on?
You can turn your mic on. I'll turn the podium just because it tends.
Check. Hey.
Just a quick note. When you're doing a voting question, pause for a minute until I kind of give you a signal.
Yeah.
Because to get the results, I have to hit return.
Sounds good. Can you guys hear me at the back? Do you want me to use it, or can you hear me just like that? Use it? Okay. All right. My name is Prashant Natteru. How many of you have a difficulty pronunciating my last name? Show of hands. It's okay. I feel it every day. So the way I try to simplify it is I just go by Prash. Easier, right? I'm a PGY3 neurology resident. I'm actually 4 years away from paying off my student loans. So I thought that was important for you guys to know, because you have to plan when you start residency and when you can start paying off your student loans, right? Because the system here is we have a huge ton of student loans. All right, moving away from politics and policies. Before we begin, what's the mood of the class today? And I'm a Star Wars fan and I put this up here because December 20 is when the new Star Wars is coming in, right? So if you guys could vote as to what the mood is. It's not a trick question. I just want to gauge what my audience's mood is today, since it's a Friday. Expected. Yes. If I didn't have to be here to lecture you guys, I would be in the same mood. Okay? So I agree with you all completely on that. So we'll try to make this not 2 hours, because when Dr. Paul told me it needs to be from 1 to 2:50, it's like, as a medical student, I was never interested in a 2-hour lecture. I was like, maybe 10 minutes tops is when my attention just wanders, and I'm thinking, which bar do I go to today? I'm like, fine. All right. That being said, we'll make this as interactive as possible. My focus on this PowerPoint and the presentation is not to test your knowledge, but just to give you a brief idea of what seizures look like. Okay? All right. So moving on. How many of you know what seizures actually is? Show of hands. Okay, good. All right. I was expecting nobody to raise their hands so that I can teach you. Okay? So, in general terms, when I was a medical student, and I'm trained in India, all right? So I was born and raised in India. I moved here in 2017 for my neurology residency. Whenever, like, I was a M3, M4, we used to hear seizures. The first thing that comes to mind is, right? But once I was when I was M4, I was shadowing a neurology attending, and we were rounding on a patient, and the patient was being just hostile to the attending. And we were like, as M4, I got riled up, and I was like, what the heck, man? What's going on? So my attending was like so calm. He was like, let's talk outside. So we go outside, and then we go to the EEG room, and there we see that he shows a few spikes, something like that, okay, from the EEG. And I was like, I don't know what you're talking about. How many of you know the show Different Strokes? Right. So, now one guy there, this reference is for you, you will get it. So I was like, what you talking about, Willis? Okay. Might have heard of it? Yeah? Okay. So the same thing happened. I asked my attending as to why is this happening? And he said, this is something called as ictal swearing. In our terminology, ictal basically means seizure, and swearing is, being hostile. So it's a phenomena that happens. It's pretty rare, and you can get that with a seizure, okay? So at that point in time when he told me this, I was like, everything that I learned in neurology just was like, just vaporized. So coming back to the basics, what is a seizure? There are a lot of words there. I had to put it because it's an academic session. But in simple terms, for our convenience today, that whole side is the left side of the brain, okay? This is the center, and that's the right side of the brain, okay? Imagine, you guys have heard of Mexican Way, right? Can you start from there? Let's go all the way to that side. Let's start. Go. There. Great job. This is what a seizure is. Starting from one aspect, could be the right or left, and then if it just starts there and it ends there, can you guys just do this? Right. No, not you guys. This is the center, right? So the right side of the brain is just firing right now. Center's calm, the left is calm. So that would be a focal seizure. The first thing that we did, starting from there and spreading to the other side, was a focal seizure spreading through the center to the other side where the body will have generalized tonic-clonic, right? Make sense? Okay. So the definition of seizure here is hypersynchronous or abnormal firing of neurons, right? Now, in simple terms, you can have a clinical seizure, which is that one, or one-sided, or just lip smacking, or chewing movements, or sometimes just blank stare. That's a seizure as well, all right? And we'll go through the classification as to what's a seizure and what's not. So one on your right side is a clinical seizure, where somebody had a seizure and you see them, they're post-ictal right now. Post-ictal is basically after a seizure, okay? The one on the left is, you don't have to be a neurologist to know what's going on. In simple terms, you see abnormal spike and wave. You guys see that? Right there? So it's just generalized spike and wave discharges. That's basically a seizure, but we call it subclinical or electrographic, which is not obvious to the eye. Simple? All right. What is epilepsy? Epilepsy is if you have repeated seizures, at least 2, without a brain insult. So what happens is, in pediatric populations, how many of you guys have done M2s? Do they do? No, Pete. I'm sorry. Okay. Sure. So how many of you have seen a child having seizures? Okay, 1, 2, 3, 4, I'm bad at math. About 10? Yeah. Okay. So when they have seizures, the etiology changes completely. It's because of malformations of the brain. There is some infection in the mom that gets carried over to the child, and a bunch of other stuff. So moving on. How common are seizures? I'll wait for you to take the poll. I know, I would, yeah. I'm sorry about this. Close. All right, so the answer is 1 in 26. It's a stat that came up from American Epilepsy Society and Epilepsy Foundation. So they put up this and they said support because 1 in 26 people have seizures. So that's the reason. You guys have a PowerPoint by Dr. Ingram, correct? Yeah. So I didn't put in a lot of stats and all of that here. I just put a lot of clinical stuff because this is something that you might not see. Oh, just a hint. You guys have small groups after this? Seizures? I promise you, if you listen to this, you will ace that. Okay? Just saying. Okay? All right. So coming to the seizure classification, and this is the one chart that we will refer to the whole time today in terms of all the cases we go through. Yeah, I think it's on Canvas. You can, which module?
It's in
The same module, yeah. I'll wait for you guys to pull up. Okay. All right. So when I was in my PGY1 of neurology, there was a different classification of seizures. You guys might have heard of these terms called simple partial, complex partial, generalized tonic-clonic, and complex partial with secondary generalization. Yeah? Okay. So when I started that, I was like, yeah, I got it. But then International League Against Epilepsy in 2017 flipped the whole thing again. They said, no more simple partial, no more complex partial. We'll talk about seizures in terms of it being focal or focal to generalization or generalized. Yeah? That's what they did. Bunch of losers. But because what happened was most of the terminology you learn and come into med school and you're like, oh yeah, this is a simple partial. And they go like, sorry, focal aware. And then you're like, okay, fine. So we start with focal onset seizures, right? So focal, like I said, it's in one part of the brain that can start. For example, I'm sorry, I'm pointing it out to this side just because you guys started the Mexican way. If they would have started it, I would have said them, okay? So focal could be that side or this side of the brain causing the pathology. How would a patient manifest with a focal seizure? And that's why this classification is important. The first thing you want to know is the patient aware or not aware? When I say aware is when you ask the patient, were they aware of their surroundings? That is awareness. If they know they're having seizures, that's not awareness. A surrounding is if somebody is calling them out, like, hey, wake up, and then you ask them after the seizure that, were you able to hear this person calling out your name? And then they said, yeah, I could. So that's when you realize that there is awareness, okay? So the first step is to decide whether if somebody is focal, and if they are focal, you want to decide whether there is awareness or no awareness. Once we've decided that, then we go to deciding whether it's motor onset or non-motor onset. All right. So how many of you know what the first one means? Automatisms. Right. Good. Any other beliefs other than lift smacking? Buttons. Good. Good. Sorry, what? That would come later. You see that part? Where's hypermotor? Hyperkinetic, there. That would be bicycling. But automatisms could be as simple as lip smacking, chewing, or fumbling with your clothes, buttons, or as simple as this is not actually a seizure, but in neurology, this is called tardive dyskinesia. I don't know if it was part of step 1. I think should be. It's been a while I've taken my steps, so kind of off. The second thing is atonic seizure. Atonic is basically, as it says, no tone, right? So a person might be walking, but remember, this is focal onset. So it can't be the whole body that loses tone. It's going to be one arm, one leg, which just goes limp, and you're like, what's going on, right? So that's atonic. Next we'll talk about is clonic. What is clonic? This is clonic, or this is clonic? Yeah, so tonic is stiff. Clonic is the thing that follows after the tonic movement, after the stiffness. In terms of, you can imagine it this way. If you're tied down like this, right? This is the tonic phase. Let's say somebody cuts open your ropes. What do? That's clonic, yeah? Something like that, just to remember. What is epileptic spasm? Pediatric, because the epileptic spasms is, anybody heard of infantile spasms? Okay, easy. This month is actually infantile spasm month, okay? So I'm gonna tell you a little bit about that. It would usually be in an infant, like the name suggests. All they do is this. Imagine, I mean, I can't show you lying down here, but imagine I'm lying down right now. And all I'm doing is briefly, maybe every 5 to 10 minutes, I just do this. And then I cry. Can't right now, but imagine. Okay? And then, so that's epileptic spasms, right? After that, we'll talk about hyperkinetic. What's your name, sir? Brian. Ryan or Brian? With a B. Okay. So Brian had suggested bicycling or pedaling. That's hyperkinetic seizure. It's basically you're very violent in terms of your aura. These are all aura, like part of seizure phenomena, where you're like patients who have seizures in their frontal lobe or temporal lobe sides, they bicycle or they become really agitated and they want to walk around. So that's hyperkinetic, okay? After that, there's myoclonic. Myoclonic is very simple. USMLE step 2 takers here? You all have to take step 2, right? Are you done with step 2 or no? No, not yet. Okay. Sorry. So I told you, I apologize. See, I grew up in India where we take our steps after med school because it's not a part of our curriculum. So I don't know when you guys take steps, okay? My apology for that. But USMLE step 2 takers, the important part that you need to remember with myoclonic seizures is the stem will have something like patient complains of generalized tonic-clonic seizure, blah, 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 blah. Keywords, right? You need the buzzwords. The buzzwords is complaints of dropping things from time to time, especially when waking up in the morning. The most common would be toothbrush or trying to lift a glass and then they drop it and you're like, the primary care is like, okay, what do we do here? Because I don't blame them. It's that they've never heard of it, what myoclonic epilepsy is. And this is what myoclonic epilepsy is. Like the patient would be having breakfast or even like sitting and talking to you and suddenly their arms will go just like, and you're like, what the heck? What's going on? It's like, I remember I was teaching a bunch of medical students and I showed them that and we're like, why is he doing that? Like, this is myoclonic epilepsy, all right? It's not, you can't see me. All right, so I already spoke about the tonic phase with you guys. Now coming to the non-motor. The non-motor aspects of seizures is basically, the first thing that we talk about is autonomic. right? Autonomic is the heart rate goes up, the blood pressure goes up. When you're having a seizure, especially when it's in the side of the brains here, like insular region, where your centers are in terms of controlling your seizure activity, they will give you autonomic seizures, where you'll have tachycardia, bradycardia, hypertension, hypotension, stuff like that. Behavioral arrest. Okay. What is behavioral arrest? That is behavioral arrest. Okay? I had to show it to you. I can't write it down. When somebody's talking to you, suddenly they stop talking and then just daze. And then it takes about a minute, 30 seconds before they come back, and they were like, what'd you say? I was like, I think you had a seizure. Okay? So, then let's go look at cognitive. Cognitive is basically the most common consult we get in the ER as a neurology resident is, there's a patient who has word-finding difficulty. And it could be just two things, either a stroke or a seizure. So either ways I'm getting consulted. I might as well just go see the patient, right? I can't argue with them at that point in time. So cognitive is patients have word-finding difficulties, aphasia, they're not able to describe their name. Like when you ask them, they're like, so stuff like that. So that's cognition. Next, let's go to emotional. Emotional is sometimes prior to a seizure or during a seizure, you can hear patients go like, oh. So that's like a cry, yeah? So that's an ictal cry. A lot of things in neurology can be attributed to seizures, but there are certain things in neurology that cannot be attributed to seizures. We'll see that later on in our PowerPoint, 127. So when do you guys want to take a break? 150? Okay, all right. Like I promised, I'll wrap it up quickly, okay? Generalized onset is motor, tonic phase, clonic phase, then clonic, tonic, myoclonic. It's basically the whole body, just like how it was focal, now it's generalized, right? Then we talk about something called as non-motor, which is absence. How many of you knew that it was absence and not absence? Up, up, up. Good, good. All right. Do you all take French lessons? No. Okay. All right. So, with absence seizures, the typical ones are usually described in children, and they are the most notorious kids in school because they just don't pay attention. Most of the times they're branded as ADHD or lack of interest, and their parents are always, going to the school. It's like, your kid never focuses on things, and what do we do? Because it's not his problem. We haven't identified the problem that it's absence seizures, where the guy is just staring with a few blinks. And that can't be a lack of attention because the child is having a seizure, right? So that's absence. That's typical. Atypical is slower in onset, takes some amount of time before this manifests, and even the coming out of a seizure is slow, all right? Eyelid myoclonia. This was interesting for me. So, I don't know, the last people at the back can't see this, but what I'm trying to show is eyelid myoclonia, where my eyes are rolled up and I have rapid fluttering of my eyelids, okay? I'll try to do it. If you can't see it, I'm sorry. All right. I know I look like a stupid person here, but that's what it is, okay? All right. The other aspect is unknown onset, and we won't talk about all of that. Okay, so like I mentioned, what's focal, what's generalized, what's unknown, all right? So a focal can generalize like we did a little while ago in terms of the Mexican wave. Started there. If it just stayed there, then it's focal. If it moved, involved this bunch of people, and they were like, oh, we don't want it, go to the next side. So they pushed out there, and then it's generalized, okay? All right. Some terms we need to know for the class, I've already described it to you. The awareness, autonomic features. Oh yeah, one thing I forgot to mention in the autonomic features is sometimes patients will tell you when you go on clinical rotations, irrespective of neurology or not neurology, you guys will manage seizures. It doesn't matter. I mean, as a medical student, I have to be like, oh yeah, I'm not going to be a neurologist. Seizures I will never see. But once I became a resident, then I'm seeing that I get consults about seizures from every service. And the consult that we get is not that the patient is having a seizure. The consult is, we saw the word seizure on the chart, so we want a neurologist on board. Okay? So you guys, whichever profession you go to, orthopedic, surgery, OBGYN, family medicine, whichever, you will encounter patients with seizures. So my aim of this talk is to just give you basic information to survive wherever you go. Okay? I would like for you to apply to neurology, but if you don't, I won't hold it against you. Okay? All right. So the epigastric sensation sometimes the patients describe is stomach uprising. They feel like their stomach's coming up, like a sensation that's coming up all the way, and they feel nauseated. Besides that, they can also describe that they have déjà vu and jamais vu, or jamais vu, however you want to say it. How many of you know what's déjà vu? Okay, all right. It's basically a sense of familiarity that patients have, and that's actually a seizure phenomenon. I mean, most of the times we have déjà vu, but that doesn't mean we're all having seizures. You have to see that in the context of a clinical event. Yeah? Jamais vu or jamais vu is a sense of unfamiliarity. Like, you have done these things a couple of times, but now because of a seizure, you're like, I don't know what's going on. Yeah? All right. So, the first case. This is a 27-year-old man after experiencing an episode of loss of awareness. I'll put this up here, but if you guys don't mind pulling up that classification on your computers so that we can go through it simultaneously. That'll be faster. Yeah? So the first thing that they said was loss of awareness. So on your table, what do you think this is? What's going on? Which seizure would this be? Just throw it out. It's okay. If you don't want to be visible, just say focal. I hear music. But that's fine. It's soothing. So what do you think is going on with loss of awareness? Focal or generalized? Simple. Louder, anybody? Focal. Okay, good. All right. So his friend reported that while he was eating dinner, he acutely stared off. Amongst the classification, what would you take there if somebody stared off? Behavioral arrest. Good. And then followed by lip smacking, chewing movements, and clenching of his left hand. So I will demonstrate this. Okay, right? So you saw chewing movements, you saw some lip smacking, you did see my clenching of the left hand. So where do you think, the past medical history and all is important, but just for this discussion, focus on that chart, okay? So it lasted for a total of 90 seconds, and then he appeared confused. So one common phenomena you will find with a lot of seizures is right after the seizure, if the patients are confused, and that's what we call post-ictal state, right? Pre-ictal, ictal, post-ictal. Pre-ictal is when you're looking at the lip smacking, chewing movements. Ictal is when I'm this, and post-ictal is I'm like, what you talking about? Yeah, so that's that, all right? So in this case, we're describing the whole seizure. Now, let's move. Physical neurological examination, all unremarkable. So what features did you pick up from the classification we just spoke about?
Okay, what you talking about was great. I like turtles. Stirring music, behavioral arrest. I don't know what this means. Can anybody explain to me what that means? It doesn't have to be the person who typed it, but just tell me what's the context of that. Ah, gotcha. See, I'm not from here. Sorry. Didn't get that reference. Loss of awareness. Okay, good. So we got most of it, right? Okay, that too. Fine. So let's dissect this one as to what we saw. We saw loss of awareness, acutely stared off, lip smacking, chewing movements, and then clenching of his left hand. He then appeared confused, right? So was back to baseline about 10 minutes after the episode began. So you're all convinced it's a seizure? Yeah, pretty much. You can tell this is a seizure. That's all I want you to tell. If this is a seizure or not. And then second thing I want you to tell if it's focal or generalized. Focal or generalized? Focal, good. So, focal onset, impaired awareness, automatisms, and that's all. That's all we have here, yeah? I don't expect you to know what part of the brain we're looking at, but just with your eyes, can you tell me if you see anything abnormal in that? Where? Oh, that's great. In the hippocampus, straight. Okay. We have overachievers in this class. So you see that? The simple terms is, to start with, I wanted to start with, which is the right side, which is the left side? Or my right is your left, or your right is my right? Maybe? No. Okay. All right. So this is the radiologist's right, or neurologist's right, or any imaging you look up, they usually put up a symbol R here, and that's how you can tell. But if there's no symbol like in this picture, because I'm evil, I wanted to confuse you. So that's the right side, okay? So if you look at that, that's the problem. And the MRI shows atrophy of the right mesial temporal region. It's close to the hippocampus, that's true. Do you guys want to know what's the coronal, what's sagittal, and what's axial sections, or you already know? We know? Okay, great. All right, so just like how we have an EKG for the heart, we have an EEG for the brain. When I was a medical student, M2, M3, I used to just look at it and it was like a bunch of squiggles. Yeah, that's all that's to me. But as a neurologist now, or neurology resident, I appreciate it much more than what I did as an M3, because now things have started to make sense to me, okay? Just to your eyes again, anything abnormal? Where? And again, in this, what's left, what's right? Are you able to see the numbers there on the side? Oh, on your screens you can, provided you have it pulled up. Yeah. So the evens are right, and the odds are left. So where's the abnormality? Left? Right? How many hands for right? Okay. How many for left? That's fine, that's fine. How many for not right, not left, or both? Okay, good. All right. So if you look at, this is the left side, right side, left side, right side. Now, I won't tell you which part of the brain these are, but in simple terms this is the abnormality, okay? This is called a sharp, and this is called a wave after it, right? Or spike and a wave. So you see a spike and wave complex in the right side predominantly. But you might question me, like, this is also the right, why am I not seeing it? Because that is the front part of the brain. The seizures are coming from the temporal lobe, which is the back part of the brain. And that's what this is, okay? All right, so what was it? Awareness was impaired, this would be classified as a focal impaired awareness seizure with automatisms, right? The seizure combined with the MRI and EEG findings suggest focal epilepsy. You will treat it, blah, 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 blah. We'll not go there. All right. Sir, the first one, please. Some video aids for you guys. We're not allowed to share patient information, so most of the videos are from YouTube, which are accessible to all of you.
You're fine, Adam.
Good enough.
He's having a seizure. It'll pass. He's okay. You're okay. You're fine.
It happened again?
He just had a seizure.
It's a little dramatic, but yeah, more or less. Yeah.
Something strange.
You can see him looking at the chart. We're looking at least.
You did what you told him to do, honey.
No, this is gonna be very weird.
Why?
Because he has. Look.
There's a camera.
Look.
He's doing a documentary on you. We're gonna send it to Dr. Filming. $1 million.
Oh,
What do you see? What is it? What do you see, but?
Such a handsome young man.
Who's that? Okay, so this would be complex partial.
Yeah, just for the virus. August 22nd, 2009, 3:14.
What? What do you see? Look. What is it, baby? What do you see, honey? Hey, look at me. Babe, look at me. Hi. How are you? You're gonna wait a minute.
So, yeah.
How do you tell the difference between like behavioral arrest and absence?
So absence, right. So absence, good question, firstly. Absence versus behavioral arrest. Behavioral arrest is just staring. Absence is you have fluttering of the eyes. And that's absence, okay? But in these three examples that you guys saw, what are some of the, the word is semiology. When you are describing a seizure, and you will come across this, neurologists, just to look smart, they like to describe terms like the seizure semiology is blah, 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 blah. So what is the seizure semiology that you guys saw in these three? I'll start off. I saw dystonia. But what are the others that you saw? Automatisms, good. What else? Just remember the guy, not the first guy, the actor drama. No, not that one. The second one where there was a lady sitting with a guy and he was pointing to the camera, and then suddenly I can describe three things. One, behavioral arrest. He stopped. Two, he has automatisms. And then he had the arm, either you can call it dystonia or a motor phenomenon. Okay? So those are the three things you saw in that one. The last video that you saw where a person was walking and they saw flashes of light, that's a sensory phenomenon. Okay? You can see that with migraines as well. How many of you here have migraines? I'm guessing a lot of medical students have migraines. No? Oh, trust me. When you come to the residency side, everybody will have migraines. Yeah. I'm sorry. That's our world. That's how it is. Okay. So we're done with that. Now, this is the question. Just have to sound academic. I can't show all videos. So. 40%, 20, okay. All right. I mean, then 60% is the answer, okay? So if you have a patient who has a seizure and you don't treat them, the risk of them having a second unprovoked seizure is about 60%. And you might have heard of a term called SUDEP. Have any of you heard of SUDEP? Sudden death in epilepsy. So when I was a medical student, they used to talk about moms having seizures, and when babies are sleeping right next to the mom, they have a risk of asphyxiating them if the mom has a seizure. But now American Epilepsy Society has moved away from this, and they're generalizing everybody and saying there is a risk of sudden death in epilepsy with a single seizure as well. Okay? And the seizure does not have to be the whole deal. It could just be patient is having a focal seizure, aware seizure, and that still could cause death. Okay? So that's why this is important, that you have to treat. All right, let's break. 147. Go ahead. No, sir. I'll just get some water. Yeah, no problem. Yes, ma'am. Yes. Sorry, let me just turn this off. Don't want everything.